Welcome to Save Your Thyroid, a podcast all about thyroid nodules. My name is Jennifer Holcomb, and I advocate for fellow patients suffering with this very common condition. Thyroid nodules impact 70% of adults in their lifetime, and the standard of care is surgical removal of half or all of the gland. But in recent years, safe and effective non-surgical treatment options have become available. In this podcast, I sit down with patients and physicians to discuss life with thyroid nodules, treatment options, and how to save the thyroid whenever possible. Today's guest is Dr. Vaninder Dhillon, an assistant professor of otolaryngology, head and neck surgery at Johns Hopkins University School of Medicine, practicing in Bethesda, Maryland. She is dual fellowship trained with expertise in thyroid and parathyroid surgery and radiofrequency ablation for benign and malignant lesions, as well as laryngology, which includes voice and swallowing disorders. She has a clinical interest in laryngeal outcomes after thyroid and parathyroid surgery, as well as radiofrequency ablation. Dr. Dhillon, it's wonderful to see you again after seeing you a few months ago in Baltimore. Welcome to the podcast.
Thank you. Thanks for having me.
I learned after we decided to do this interview that a major focus of your work is actually on the voice and swallowing in terms of thyroid surgery and thyroid procedures. We're going to cover a lot of how that relates to thyroid RFA. For patients who are not really familiar with the term laryngologist, do you want to give us kind of a broad overview of what that is and how that has to do with what we're going to talk about today?
Yeah, sure. So laryngologist comes from the word otolaryngologist, which is basically an ear, nose, and throat physician. And in that ear, nose, and throat, the laryngologist is the throat portion. So laryngology is a subspecialty of ear, nose, and throat. And it really focuses on the larynx, which is an organ that is responsible for voice and swallow and basically your upper airway. So that's sort of the fellowship that I took part in when I finished residency, and then subsequently did the endocrine fellowship. So I sort of had that dual background, but a little unique take on functional outcomes with regards to voice and swallow.
And you do just endocrine surgery.
Endocrine, head and neck, so thyroid and parathyroid.
So for those of us who are not as versed in the anatomy, myself included, I actually did kind of brush up on my anatomy a little bit before this interview. Tell us a little bit about where the larynx is in relation to the thyroid.
Yeah, that's a really good question. And just so you know, even when I was a resident, I didn't understand the larynx. It had to take a whole extra year to really be like,
Wow.
Okay, that's the anatomy, because that's all we focus on. So it's a very hard concept anatomically for people to understand, but it's really simply, if we think about the head and neck as everything above the collarbone, our thyroid gland, and I'm using my fingers here, sits sort of right at the border of the collarbone and the neck. And so our voice box is just above it. So it's not directly behind the thyroid, but above it. So typically in men, we appreciate the larynx with the Adam's apple, or what's called the thyroid notch. And women, we can feel it too, depending on our neck anatomy, but it's sort of that protruding cartilage that kind of comes out to the front of our neck, and that is sort of the middle of the larynx. So the larynx actually extends higher than that. And if we think about voice and swallow, behind the tongue, which is sort of the back of what we can see when we open our mouth, just a few inches below is the beginning of the voice box. So it really extends from above that sort of protuberance or that notch to where we would think the thyroid gland is. And then below that is the trachea, which is our airway only. So It's a unique structure, and it's sort of the structure right behind the thyroid, in the sense of what sits behind in the deeper structures. Behind that is the esophagus. So they're two separate things. The voice box is in front of the esophagus, but yet the voice box is also responsible for how food and liquid and everything goes down the right tube. So it's a unique placement of the structure.
Wow, it's a lot. I was looking at multiple different diagrams just to see where all the different structures are in the neck, and I think I had a really, for a layperson, a pretty good understanding of the thyroid, the parathyroids, and all of the other things down in the lower part. But the larynx is not something I've ever really looked at before. And I know we talk a lot in regards to RFA, the recurrent laryngeal nerve, and how it's so important to stay away from that area that a lot of doctors call the danger triangle. So I wanted to ask you this question about the recurrent laryngeal nerve. Does it pass between the thyroid and the trachea, or is it actually inside of the thyroid tissue? I think I've heard that it was inside of the thyroid tissue. Is that correct?
Yeah, that's a good question. So just to give context for the larynx and the recurrent laryngeal nerve, the larynx is a structure within the internal anatomy of our throat, our airway. So when we talk about the thyroid gland, it's in the neck. So when we talk about RFA or thyroid surgery, we're making incisions or we're putting an electrode through the skin, which directly makes contact with the thyroid gland in the neck, and the recurrent laryngeal nerve, which sits sort of to the edge of the thyroid gland, in between the thyroid and the trachea. So by definition, the nerve is not within the gland, but in some patients, it can actually be sort of embedded in the gland, even though it's a separate structure. It's not part of the thyroid. The larynx, on the other hand, the voice box, all of that is within its own sort of tube. So that is not anything we actually intervene upon when we are doing things to the thyroid gland. But because the nerve is in the territory of the thyroid gland, if we, like you said, get near that danger triangle, or actually inadvertently hurt the nerve in any way or injure it, it directly affects the internal function. So that's kind of the relationship between the two.
The danger triangle and the recurrent laryngeal nerve is something that a lot of patients ask about, particularly when it comes to thyroid cancer being treated with RFA, because so many patients seem to have thyroid cancers that are back towards the nerve. And so they're very excited about RFA, and then they find out they're not really a good candidate because of the location being so close to the nerves.
So I think the most important thing to discuss is the recurrent laryngeal nerve in relationship to any intervention to the thyroid gland, because really that is one of the most common complications when we think of thyroid surgery. And even that is relatively low in very high volume surgeons' hands. Right. So when we talk about rates of injury to the recurrent laryngeal nerve, and keep in mind, there's one per side. So we have two recurrent laryngeal nerves. So the rates of injury to one and or both, are really less than 1% when we think of averages. But that's, again, in very high volume surgeons. So we have to keep in mind that experience and, good technique are important in really not injuring the nerve such that there is a detriment to voice and swallow function. Even with RFA, I think it still pertains in the sense of high volume and experience, because that nerve now, even though we are not operating and opening the neck and, using cautery or knives to incise the thyroid gland, we're using an electrode, which still at this time produces thermal heat. We can still be too close to that nerve and cause potential injury. That injury rate is much lower, even less, way less than 1%, if almost very, very rare,
Mhm.
but it's still something that we know can exist. And we know that also because in RFA, a lot of us perform the procedure in awake patients, in patients that are able to vocalize to us versus surgery where we're not hearing voice. So in that sense, even if we are close with the electrode and there is a change in voice and there's a concern for any injury to the nerve, we are able to potentially reverse it or stop the ablation and wait for the voice to recover. So I think that that is a benefit to RFA over obviously surgery at this point in time. But at the same time, it's really important to understand that that nerve exists in a very distinct territory, regardless of the intervention. And that if we are going to alter it, the consequences to voice and swallow can be pretty dramatic in the sense of if it's and when I say dramatic, you can have immediate voice changes, you can have swallowing problems, aspiration. Lots of patients can also have subtle problems where they may have changes in pitch or vocal fatigue. And it's not so distinct as I lost my voice or I'm having so much trouble swallowing. It's very subtle. And so, we have to keep that spectrum of symptoms in mind when we're performing RFA as well. Because even though the rates of injury are very, very low, the nuances of a patient's voice and swallow function aren't something we should just overlook, even if it's small, because we could still potentially be injuring something or, having some sort of detriment to that function that we really need to evaluate.
In terms of surgery, if the nerve is injured, the recurrent laryngeal nerve is injured or severed, on one side, does that mean that side, that vocal fold on that side is no longer able to move and function?
Yeah, if there's a severance or if there's a complete transection, meaning it's cut, unfortunately, yes, that's a permanent injury. However, you could have lots of transient or temporary injuries where there is no mobility of the vocal cord on that side for a certain period of time, and then it recovers depending on, if it was heat energy or if it was pulled on during surgery or, there was a small branch of the nerve, which the nerve in every patient is very different.
Right.
So the anatomy can have its nuances during surgery. And so, yes, there can be transient and or permanent weaknesses or immobilities to the actual vocal cord, which is in the voice box. So hopefully we don't want the permanent ones.
Exactly.
But even the transient ones can cause a significant consequence for patients post-operatively.
Once there's a severed nerve, there's no going back from that.
Unfortunately, in regards to mobility, there isn't. There are things that we can consider if there is a certain amount of knowledge and experience by the surgeon, such as nerve anastomosis. So you can actually, if there's a cut nerve, you can find adjacent nerves in the neck to sort of reconnect to.
Oh,
and
interesting.
You can actually regain some tone of the muscle. It doesn't mean that the nerve is fully functional such that the muscle, which is the vocal fold, will move again, but it's a better outcome when it comes to voice and swallow because the muscle has not completely atrophied. So that is something that we can consider if again, it's very operator dependent, right? The surgeon has to be aware of that and be able to consider that as the next step in the same procedure, basically. But if, it is cut or, left sort of permanently transected, or unfortunately, if there's also tumor on it, cancer can also invade the nerve, then we have to remove that portion of the nerve. Then there are things that we can do after surgery to the immobilized vocal fold so that a patient isn't having such significant symptoms of voice and swallow issues. But those are things that will never be reversible.
Right.
meaning that the physiology is not reversible. We can make it better, but it's never going to be back to a fully mobile nerve, or I'm sorry, vocal fold.
And in terms of RFA, if, as you said, the patient is awake and you start to hear a voice change, what are some of the mitigation strategies that you employ after that patient's voice starts to change?
So in RFA, I think that's a really, really unique benefit of having an awake procedure capability for these patients, because vocalization and really listening to the patient's voice and also understanding even their pain, like if they're feeling it in certain areas, because we can kind of localize maybe near that danger triangle if they're feeling any discomfort or pressure, we can one, stop the procedure. So abortion of the procedure or just halting it and waiting and seeing if there's a recovery is the first thing I think all of us would immediately do. Also considering that a patient, if there's any pain associated with it, if the voice is sort of significantly changed and the patient's not comfortable, sort of saying, let's come back and let's evaluate and come back at another time. So I think you can either do it temporarily or you can come back at another time. The other thing that, many of us in discussion of the procedure itself, we utilize different solutions for hydrodissection. And what that basically means is, at the beginning of the onset of RFA, we like to mobilize the thyroid gland away from adjacent structures using, D5W or certain solutions to safely protect or create sort of a heat sink or buffer from the area we want to ablate from the other structures. So if you think of the recurrent nerve, we can consider hydrodissection of that nerve away, or the danger triangle zone away from the nodule of interest. And so if there is any concern that there is a voice change during the actual thermal ablation, we can potentially infuse D5W into that area to sort of maybe cool, if it's a thermal concern, cool the area, or sort of hydrodissect the nerve away from that area that we might have ablated to see if there is a reversal. And a lot of people have discussed that as very effective in a sort of acute voice change and a recovery, such that you perform that and then you can move on with the ablation if the voice does recover. So it's an automatic real-time feedback.
And it's super rare from what I understand. Well, you said it was even less than 1% of the time when patients have a permanent voice change. How often would you say do you have patients who have this transient voice change, like during the procedure, that comes back in real time, like you were just describing?
I've not experienced it myself, but in terms of the higher volume RFA providers around the world, I think their rates are still probably less than 0.5% if we look at like the largest volume, individuals. But, I think it's a little bit anecdotal as well, because a lot of providers are having it, but they're not, it comes back because they're very attuned to that, the voice change, and they're able to, like I said, hydrodissect or stop the procedure, and then it recovers and they're able to move on. So it's never really a post-procedural complication or post-procedural complaint that a patient's kind of having to deal with after. So I think as more people continue to do RFA and more patients seek RFA, as our numbers continue to grow, we'll probably have a better understanding of what those rates are. But at this point in time, it's very rare. And I think the transient ones are very transient, rather than they're post-procedural, they last a few months, like in surgery, and then they recover on their own, right? Sort of like we expect recovery, we hope for recovery. This is like it happened, a few minutes later, half an hour later, it came back and we moved on. So I think that's the difference, is the time frame for these recoveries.
In our community, we're up over 6,000 members now. And out of that number, I think we have had one patient who had a permanent voice problem that lasted I think at the last time I heard it was over 6 months. So she was seeking some therapeutic options to remedy that. And then other than that, we have had maybe one or two who had transient voice change that reversed within a period of a month or so. And then we've had just a small number, maybe a handful of patients who experienced voice change after they went home, which we determined was from swelling, pressing on the nerve rather than, actual thermal damage. As you said, it truly is a very rare side effect. So it just is it tells just exactly how safe the RFA procedure truly is. I know we've talked a lot about the voice. What about swallowing? In terms of swallowing, what does the larynx really have to do with that function in terms of where the thyroid is also?
Yeah, so the larynx in general protects, it's involved in swallowing in such that there's a lot of muscles surrounding the larynx that are really meant to, when we swallow, protect the airway and not let things go down the wrong way. That's the simplest thing. We're not choking, we're not coughing things down into our windpipe. That's the goal of the larynx, is to close everything off so that things, when we're eating, go down into the esophagus, which, as I mentioned before, is behind the larynx. And so when we talk about procedures to the thyroid again, and we talked about the relationship of the recurrent laryngeal nerve, injury to that nerve, a lot of people associate with, this nerve is going to the vocal fold, and therefore the vocal fold won't be moving, and therefore, our voices are going to be permanently altered. But at the same time, that nerve sends branches to the back of the throat and the esophagus. So, the upper esophagus.
Mm-hmm.
And so when we're considering swallow function, one, if you have a immobile vocal fold, things will go down the wrong way because they're not closing completely. Vocal folds are meant to open in sort of a V-shaped function and close in a tight seal. And so if you have a weak, flaccid vocal fold, unfortunately, then you're never going to get that tight seal and things are going to go down into the windpipe. That's
wow.
So there's a risk for aspiration, but also the nerve sends branches to the back of the throat, which, as I mentioned, the esophagus is behind the larynx, but the throat and the esophagus are interconnected. So when we're pushing food down into the esophagus, it requires pressure. It requires sort of like a peristalsis, or a movement of food down the throat into the esophagus. If there's weakness in the esophageal muscles and the throat muscles, then food will not go properly into where we want it to. And so it feels harder, it feels different, it feels like it's stuck. So these are other complaints patients can have versus I'm just choking or coughing on my food. It's like, I can't get it down. And so we have to consider, again, that nerve has a huge interplay with swallow that is a little bit nuanced, and even laryngologists don't fully understand that function quite yet. But the nerve itself, again, has specific subtle branches that are also responsible just for swallow.
Wow, that is really intricate to consider all the different impacts.
Highly functional system.
Yeah.
With a nerve that's very important.
It's very common. I think the most common complaint we see from patients who are looking into RFA is difficulty swallowing. They have this, and this was my story too. They have this huge lump that is pressing on their throat, and they feel like every time they swallow, food gets stuck, or they have a hard time getting food down. So is that more of a problem of the thyroid pressing in on the esophagus, or is it actually pressing up on the larynx as well, or putting pressure on the recurrent laryngeal nerve?
It's so everyone's different, right? I think the answer to that is it could be all of the above, because it depends on, the anatomy of that individual's thyroid. So if it's the nodule itself, its location, if it's high up, if it's, low, if it's, causing compression on the trachea, which is causing compression on the esophagus, or is it higher up against the larynx? I think that requires obviously a very good ultrasound and a very good evaluation, if possible, of the throat itself with an endoscopy. in the office, because that allows us to see if there's compression anywhere along the inside. But, I think that it's very variable. Hopefully though, if that is the case, there's an extrinsic compression by the thyroid on that esophagus or on the larynx, that when you're performing the RFA, that once the nodule shrinks, then that compression is relieved. It's very rare for a benign thyroid process to cause compression on the nerve. When we're talking about cancers, however, we have to be very concerned potentially of the cancer involving the nerve, kind of growing around the nerve, and that's a different scenario altogether. But typically, if it's just a benign nodule or a hyperfunctional nodule, we're not so concerned that the nerve is being pushed upon. It's more that a lot of structures are kind of being compressed, and then it should be relieved with the treatment.
That was definitely my experience. Within just a few days of my RFA, I started to feel improvements, and my swallowing was so affected by my nodule. My nodule was very large. It was around 45 milliliters. And then I had this allergic reaction to antibiotics, which caused it to nearly double in size rapidly. And so when that happened, I started to experience horrible compression symptoms. And, I would become dizzy just turning my head to the side because there was so much pressure in my throat. And I want to say it was within 3 to 5 days of my RFA procedure, I noticed an improvement in my swallowing. And I also noticed a very dramatic improvement in my neck circumference. I started taking measurements of my neck before the procedure, and then every week after that for months and years. And my neck was 16 inches around before I had RFA. And now it will be 4 years in July since my first procedure. I had to have 2 procedures. My neck is 13 inches around now. So I've lost 3 inches of circumference of my neck because that thing has gone down by 90%. So it has been tremendous, to say the least, that I was able to have all of that pressure on my everything in my neck relieved. So I'm very grateful for that. And I know there's a tremendous number of patients, particularly the ones that we interact with in the community, who have experienced the same.
That's really great. I mean, if you think about 3 inches from your neck, that's a huge,
it is.
That's a huge amount lost, but also so much gain from the sense of the compression, right? Like you would think that, oh, just a few inches are gone, but that's a large amount of compression circumferentially on multiple structures, right? So, I think when we talk about symptoms that are affecting voice and swallow from the thyroid, if it's the nodule or multiple nodules, then we really need to take that into account when we're doing the RFA to say, look, the outcome should be better, like for example, in you. But at the same time, I think we have to be really prudent and thoughtful about talking about the risk to the nerve, because if that nerve for any reason is encountered during the procedure or injured, then the post-procedural consequences of to voice and swallow function can be significant and totally different. So I think that's a great concept to make sure we break down. And we really discuss, like, if a patient's presenting with these symptoms, how are we going to relieve them? But we also don't want to create new ones.
Exactly. So tell me a little bit then about the recommendations you would have for patients who are considering RFA when it comes to their voice and their swallowing function.
So I believe that every patient should really have a good anatomical evaluation of not just the thyroid, but of their larynx. And I think that, when you're seeking RFA, you should go to, again, a high volume experienced person, but someone who can provide you imaging of your thyroid in the form of an in-office ultrasound, or evaluate the ultrasound with you in real time, so you can see what your thyroid is doing. If there's, a nodule or nodules, you are going to intervene upon where they're located in relationship to, as we mentioned, the danger triangle, but other structures, your esophagus, your airway, where in the neck and where in the thyroid, is it upper pole, lower pole? and then have an endoscopy. So typically, if you go to a provider for RFA, you may not find an otolaryngologist or a laryngologist in the same office, but even being referred for an endoscopy prior to having the RFA in the community is a great idea. I'm a high proponent of that. And so if you're gonna proceed with that, you should have someone do a baseline look at your larynx. And the endoscopy that we perform is a very traditional laryngoscopy, which is done through typically the nose with topical anesthesia. So it does take about 10-15 seconds for a look, but it's really painless. I mean, I do them every day, all day long. So, you want to go to someone that's experienced in those and have someone record it, have a baseline recording of your larynx exam, your voice box exam, and then have your RFA. And if there's any issues post-procedurally, whether or not there was any concern during the procedure, go back to that provider and compare if there's any differences in your exams, but it's recorded. So I definitely believe that a pre and post exam, laryngeal exam, is very important. And that's something we would recommend for a thyroid surgical patient or, parathyroid surgical patient. So I don't think it should be any different for RFA. And I think the other part of that is if a patient does have symptoms and they're plugged in with someone that is able to perform the endoscopy, if there's a need for therapeutic, intervention post-procedurally, you're already in with somebody. You're not sort of seeking, like, you're suffering or you're having complaints, and now you have to find a provider to kind of help, the process along, even if it is transient, right? Voice and swallow things can be transient, but you don't want to have to suffer through it. But if you have that sort of multidisciplinary team there, then you can seek therapy if needed after the procedure.
That's a great idea to have that data there, so you have something to compare before and after. Do you have any examples of research where they've compared pre and post RFA endoscopies?
Yeah, we're actually doing one right now at Johns.
Oh, wow.
I think that data is very new. I mean, it's been around a long time. There are lots of studies in surgical, in the surgical literature about pre and post laryngeal exams and the nuances of what we see. But I think if we're thinking about RFA as a new intervention, it does take having laryngologists involved, and that's sort of a new forefront to really evaluating voice and swallow in RFA patients. I think that data will become more robust as as time goes on. But currently, what we are seeing is, like I said, the rates are very rare. Patients do not necessarily complain of any voice and swallow issues after RFA, and if they did experience it, it was during the procedure and it reversed itself. So they're back to their baseline. But I think what we really need to do is implement the pre-procedural laryngeal exam. And I know all of us at Hopkins are doing it. In many institutions, we do our own laryngeal exams if, we're otolaryngologists, but, in a larger sort of context, I think we should look at that and then compare and see, even if there's not, significant voice and swallow changes, are there any subtle changes, and I think this is where we kind of nitpick a little bit. We want to know is, your voice is great, but do you have any pitch issues? Are you getting tired at the end of a sentence? Can you sing like you used to? Like, these are smaller questions that we want to know. And so I think that would be also interesting to focus on.
We actually did have a patient in the community who's a professional singer who recently asked the question, has anyone who is a professional singer had RFA and had issues with their voice? It's a frequent question that we see from a lot of patients, just that they're concerned about the changes that could happen with their voices. But this particular patient was a professional singer who would rightly be concerned about, any issues to her career caused by the treatment. But she was much more interested in RFA than in surgery for that very reason. And the comments that came from that post were all very, very positive. I remember several years ago also, my own doctor performed RFA on a professional singer and actually had her sing during the procedure just to be sure that everything was still going well. And of course she came out of the procedure just singing beautifully. So so we're very, we're seeing a lot of very good outcomes for patients in terms of their voice, and very grateful for this safe way to treat patients that most likely won't compromise their voice.
Yeah, I think from a professional voice standpoint in surgery, in the surgical literature, we do talk about the role of seeking subspecialists such as a laryngologist prior to a thyroid surgery. We do a laryngeal exam, but for laryngologists, we have a little bit more of a high definition exam called a video stroboscopy, which does look at not just the mobility of the vocal cords, but the range and the tensile strength of vocal cords, the pliability, because vocal cords vibrate against each other to create harmonic sound. So there's a little bit more nuance with the video strobe, but in a professional voice user or a singer, we recommend seeking that consultation. We also work with speech language pathologists who many are, performance level speech language pathologists for voice. So, seeking that as a baseline evaluation to kind of do a lot more nuanced measures in terms of, what is my voice now and what will it be after the intervention. I think that's very important. But I think listening to what you just said, the provider that performed your RFA, when he performed it for a voice professional, he was having that person sing. And, that is something that, is again, the benefit of doing RFA Awake is that we can hear not just the conversational voice, but we can ask a patient to stretch their voice. We can have them sing, we can have them, seek different ranges, change pitch, continue a conversation to what we consider maximum phonation time, which is, vocal fatigue. An element of is there vocal fatigue. So there are things that we can seek, measures that we can do real time during the procedure to make sure that it's still intact, which again, we can't do in surgery. And I think that is really interesting in and by itself, because there's no study looking at that, right? Like, how do we objectively measure the voice? There are measures we have, but should we be doing these during the RFA procedure itself? And I think that's a great question, because if we can say, look, the measures don't change and they're the same during the procedure, and we're able to quantify it, then we can show that RFA doesn't really do any detriment to the voice. So I think, again, we have our scope, our look, our direct visualization, but actually measuring these, nuances with the voice that are so important to professional singers or professional voice users, that would be, like, I think very, very beneficial for patients to say, look, this is really a better treatment for me because there's really no risk to my singing career, to the elements of my voice that are more important to me than just I have a voice.
Tell me just a little bit about your experience with RFA at Hopkins. You're doing these in Bethesda, correct?
Correct. Yes. I originally started doing them in Baltimore because that's where we were centered. But I have migrated my own practice in terms of the RFA itself down to my clinic in Bethesda. And so my patients, when they seek consultation with me, I do perform video stroboscopies on them because I have the equipment and I'm, part laryngologist. So we do that as part of the evaluation prior and post. But, and that's something that I counsel patients on really thoroughly prior to the procedure because if, like you said, if they're not coming in with those symptoms, like I feel like my voice or my swallow is being affected by this thyroid nodule or this thyroid concern, it's, what are the potential risks during the procedure? And we want to make sure that the outcomes, because typically RFA in it by itself is a great outcome, but the other outcomes in regards to voice and swallow are going to be good as well. We don't want that to be a new issue for patients. So they always get a pre and post video stroboscopy. And I have speech language pathologists in the office who, if there's any concerns prior, we usually send them to see them before the procedure. And then if they need to after, that's the way I practice, but that's very different, I know, for other people, but that's just unique to me because of the resources I have.
Well, do you have any final thoughts you'd like to share with the viewers?
Yeah, I just want to say thank you again, Jen, for allowing me to be on your platform. And I think that RFA is going to change the way we manage thyroid disease in the future. I think at the same time, we need to consider outcomes in the sense of, the functional quality of life outcomes that we all want beyond, what's going on with our thyroid. And that includes the larynx, our voice, our swallowing function, our breathing function. And so those structures that sit around that nodule or that gland are just as important. So, be an advocate for yourself. When you're seeking RFA, make sure that you are looking into maintaining the outcomes for the larynx. And so your voice and your swallow are very important. So make sure you advocate for that before and after. There are people in the community, laryngologists, otolaryngologists, speech language pathologists, that this is all we do. So, even though, you may be going to someone for the RFA, if there's any concerns, you should seek therapy or intervention for anything that of concern to you with regards to your voice and swallow after the procedure as soon as you can, and get that referral. And hopefully that doesn't happen, because again, the rates are so low, but just be that advocate for yourself.
That last point you made especially is so important. In the rare case that you do have an injury, you've got to be connected. As you said, it's good to be connected with someone, because RFA is still kind of a new thing. And if you just go to someone who's not familiar with this procedure, you may not get the best care afterward in terms of trying to recover your nerve. So I think that's really important and great that you mentioned that. And I think that the more, as you said, the more of these pre and post tests that are done, the more data we'll have, and the more we'll be able to see exactly what is happening and move forward knowing more and doing better.
Yeah, and providing the best outcomes for ourselves
Absolutely.
and for everyone else going through RFA. I think that that's shared knowledge, and that we should be able to do that.
Are you treating cancers?
In Baltimore, that's part of our clinical trial. So the cancers are being treated up in Baltimore. So yeah, I do go up there for those cases, but for the majority of the benign disease processes, those happen in Bethesda.
That's a big one that we're getting. We're getting lots of requests these days for patients wanting to know what providers treat cancer. And I don't know if you're aware, we actually maintain a list of the providers who do all thermal ablations in the United States and also abroad. And one thing that we plan to add to that list is one column that states, treats cancer.
Okay.
For those providers, because there are patients who are willing to travel, wherever they can go to find a provider who will do that for them, if to at least evaluate them and see if they're a candidate, and then we'll potentially treat them. So so that's exciting to know that you're doing that. I'm assuming you're doing that with Dr. Russell.
Yeah, and at least at Hopkins, we're still within a trial standpoint, but our numbers are going up, and I think the criteria we're going to reevaluate sort of what the again, based on guidelines, what we can treat. But you're right, a lot of the micropapillaries are coming our way. A lot of the, smaller, low risk cancers. And of course, obviously the recurrence and the persistent disease, but those, those numbers are steadily increasing. But yeah, we're happy to see patients and evaluate to determine if they're good candidates.
That's so wonderful. Yeah. And for the patients who have recurrent disease too, that's a kind of new world for me, because a lot of those patients have already, all of those patients have already undergone thyroidectomy. And so they wouldn't be a part of our community per se, but they might be involved with the THICA community.
Correct.
And I'm not sure if you know this, but Save Your Thyroid is actually currently under the umbrella of THICA as a fiscal sponsor. So, because one day we hope to incorporate as a nonprofit too. Whenever I learn about things like treating these recurrent disease with RFA, that's so exciting for me, because that's something I can tell, patients who are members of THICA, hey, you may not need to go under the knife again. And so, so even for those patients who they still have lost their thyroid, but they might potentially avoid another surgery. That's wonderful.
And potential risks to the recurrent nerve.
Exactly.
So, we want to maintain the outcomes that they have, and, not have to subject any further morbidity. So that, yeah, exactly. That would be a good patient population for RFA.
Well, I just appreciate you, Dr. Dhillon, so much. Thank you for sharing all of this today. I think it's going to be very helpful. I've never spoken with anyone at length about this, and I think it's going to be helpful. So thank you so much for joining me
You're
today.
welcome. Well, thank you. I appreciate the time. So I look forward to seeing you in the future.
Thanks so much for listening. Please share this content and help others. If you need resources, testimonials, and support, please join our patient community, Save Your Thyroid. You can also find me on social media and Substack under the media handle, It's Me Again. Never forget to educate yourself and be your own advocate and save your thyroid.